we're going to see the hypoglycemic medications used in diabetes 2 mellitus patients. This will be first those that increases insulin sensitivity are the biguanides, that is metformin, and thiazolidinedionas. Next, those that increases the insulin secretion are meticlinides and sulfonylureas. Those that decreases glucose absorption are alpha-1 glucosidase enzyme inhibitors. This is acarbose, and the inhibitors of sodium glucose cotransporter 2. Analogs of amylin analogs, and those that increases the insulin secretion due to glucose. This is the peptidyl peptidase for inhibitors and the glucagon-like peptide 1 analogs. Alright. So the biguanides, metformin inhibits gluconeogenesis, inhibits the glycerol phosphate dehydrogenase mitochondrial enzyme. This is due to activation of the protein kinase A after cyclic AMP releases its catalytic subunits. Metformin is the first drug of choice in diabetic patients. Metformin will not produce hypoglycemia as opposed to other medications. It also increases insulin sensitivity and will certainly decrease the glucose. Also, metformin is not used in patients with chronic kidney disease due to increased risk of lactic acidosis, even though this is rare. Other adverse effects are the most common, that are gastrointestinal symptoms and vitamin B12 deficiency. In thiazolidinediones, these are rosiglitazone and pioglitazone. These medications act as transcription factor and goes to the PPAR nuclear receptor. This increases the insulin sensitivity, one, because increases insulin receptor numbers in the cell, decreases triglycerides and glucose due to decreased gluconeogenesis. Adverse effects of these are certainly the edema, water retention, so it is contraindicated in patients with congestive heart failure. Pioglitazone also produces bladder cancer, and rosiglitazone sometimes increases the risk of cardiovascular events. Now, the insulin secretion medications are metaclinides and sulfonylureas. The mechanism of action of both is that they block the potassium channel, and so the voltage membrane increases, calcium goes in, fusion of the vesicles. These metaclinides and sulfonylureas block in different parts of the same channel. Metaclinides are repaglinide and nateglinide. They increase the cardiovascular risk. And sulfonylureas, we have tolbutamide and clopropamide are first generation. Second generation are glimepiride, glipizide, and gliburide. Gliburide, we should be careful in hepatic failure, glipizide in renal failure. And the drug of choice would be glipizide due to decreased risk of hypoglycemia. Sulfonylureas also produces weight gain due to increased secretion of insulin that promotes glucose entry into the cells, and obesity. That was the original problem. These sulfonylureas will be added usually after metformin if metformin does not function well, but there is no advantage in giving sulfonylureas or metaclinides. Acarbose blocks the alpha-1 glucosidase enzyme in the brush border, in the intestinal brush border, so decreases the absorption of glucose. the GI tract motility issues will be adverse effects like diarrhea. This is not recommended in patients with chronic kidney disease. Also, they will decrease the glycated hemoglobin only by half point. The inhibitors of the sodium glucose transporter, this decreases the glucose that is reabsorbed in the kidney, so increases the glucose and sodium in the tubular lumen. That leads to increased sodium and glucose in the macula densa. The important issue is that the increased sodium in the macula densa leads to decreased renin angiotensin aldosterone system, and so decreased pressure in the glomerular capillary, so decreases the albuminuria. And also, because there is no aldosterone that absorbs sodium and water, there will be decreased blood pressure. Adverse effects will be hyperkalemia and orthostatic hypotension, dehydration, diabetic ketoacidosis, so it's contraindicated in patients with diabetic ketoacidosis. These medications are canagliflozin, empagliflozin, what else? Canagliflozin, empagliflozin, dapagliflozin. Empagliflozin promotes these wonderful effects of decreasing blood pressure, decreases cardiovascular events, decreases the admission with patients with congestive heart failure, etc. Canagliflozin is sometimes linked to ulcers, so it is contraindicated in patients with peripheral vascular disease, ulcers, amputations, or neuropathy. Amylin analogs are pramlitininide. Remember, amylin is secreted with insulin and decreases the appetite, the gastric emptying, and glucose. So the analogs, pramlitininide, will produce increased satiety due to decreased gastric emptying, decreased glucose, and decreased appetite. So the patient will take less food. The peptidase inhibitors are saxagliptin, sitagliptin, linagliptin. These medications inhibit the enzyme, the peptidase enzyme that is the one that breaks or destroys the glucagon-like peptide 1, and this glucagon-like peptide 1 is the one that increases insulin due to glucose. These medications' adverse effects are respiratory infections and hypoglycemia. And the analogs of glucagon-like peptide 1 are liraglutide, albiglutide, dulaglutide, lixisenatide, exenatide, etc. The adverse effects would be pancreatitis, nausea, vomiting. This due to increased satiety and decreased weight loss. This is sometimes a desired adverse effect. Metformin is the first drug that we give. If metformin needs another medication to be added, usually are sulfonylureas or the peptidase inhibitors. Third drug medication could be maybe thiazolidinediones or the sodium glucose transporter inhibitors.